Right upper quadrant abdominal pain. This presentation is going to just touch upon right upper quadrant abdominal pain, possible differential diagnosis, a quick differentiation between the three that we're going to talk about, and just thinking about how they might present, why they happen, and in addition to that, how we treat them. Firstly, looking at cholelithiasis, also known as gallstones. So what is biliary colic? Well, quite simply, it's the pain that's associated with having gallstones. So this could present as a sudden, severe right upper quadrant pain that can last minutes to hours, depending on how bad the attack of the biliary colic that you're having is. It tends to be quite sharp, intermittent in nature, and the attacks as a whole, as I said, can last minutes to hours, often fairly uncomplicated. People will know they have gallstones, will have had gallstones before, and will be very aware when they're having an attack of biliary colic, and will aim to take pain relief at home to manage that pain as best they can. On top of the right upper quadrant pain, you may also get nausea, vomiting. The patient might explain that they're not able to get comfortable or keep still. They might give you a history of having eaten fatty foods, because that is a known trigger. So if the patient's come in and goes, oh yeah, actually, do you know, I had a fish and chip takeaway last night, that will help guide your diagnosis when thinking about abdominal pain on the whole. So the risk factors can be remembered by the 5 F's. So fat, female, 40, fair, and fertile. And evidence has shown that this group of people tend to be the group of people that are at the highest risk of suffering from biliary colic. Now, as I said, often biliary colic is quite uncomplicated. So you'll have these attacks of pain, they'll subside with analgesia, and although it's horribly uncomfortable and horribly painful for the duration of the attack that they're having, it settles and there's no infection and no complications. So really, the best treatment for these patients is to modify their lifestyle to address the risk factors. So if they're overweight and have a poor diet, they want to change that. And then thinking about appropriate analgesia. So these, in mild attacks, this pain might be blunted or sent away by your simple over-the-counter analgesia, such as your ibuprofen or your paracetamol. But occasionally you see patients who have really, really bad bouts of biliary colic, and actually they need to come into hospital for slightly stronger pain relief. It's not unheard of to have to give these patients morphine, IV morphine on occasion. And my rule of thumb is, if we're giving somebody IV morphine for pain, they probably shouldn't go home until they've had a decent period pain-free, because as we know, analgesia wears off, and the worst thing you can do is give somebody 10 milligrams of IV morphine, send them home because they feel comfortable, and then they rock up again in 3 or 4 hours time and that IV morphine is completely out of their system with the pain that they had when they arrived the last time. Moving on to cholecystitis. So this is a step up from your gallstones. This is an inflammation of the gallbladder, so an infection of the gallbladder. And it can occur sometimes because you have an obstructive gallstone. So very similarly, you would tend to get your right upper quadrant pain radiating to the back of the shoulder tip, nausea and vomiting. However, these patients will tend to be systemically unwell because they have an infection, so expect a fever, and in more extreme cases, a tachycardia and nausea and vomiting, as I said, rigors. So when we're investigating it, it's important to make sure that we're doing blood tests to confirm or exclude that diagnosis. Signs on examination, there's a sign called Murphy's sign. So Murphy's sign is when you get a pain and a rest of inspiration as your fingers touch the gallbladder. So I would put my hand in the right upper quadrant, get the patient to take a deep breath in. In doing so, this actually moves the gallbladder downwards, meaning that my fingers can make contact with the gallbladder. Obviously, this is going to be exceptionally painful in somebody that has an inflammation of their gallbladder, but Murphy's sign is actually only positive if you can reproduce that in the left upper quadrant. So again, how we would manage these patients, you would manage these patients how you would manage any other patient with an infection, be that a chest infection or a UTI infection. Your A, B, C, D, E, make sure they're hemodynamically stable and as clinically well as can be expected. We ensure they have good analgesia, and we make sure they have fluids and antibiotics as soon as possible. These patients generally will need to come in for IV antibiotics, so you'll be making a referral to the surgeons for an admission. If people have recurrent bouts of cholecystitis, they will likely be considered for a cholecystectomy, which is rarely ever done when your gallbladder is inflamed, so you'll be treated with antibiotics and then come in and have the operation done when your gallbladder isn't infected and isn't inflamed. So cholangitis. So this is an inflammation of the bile duct and can be can be diagnosed using Charcot's triad for cholangitis. So that would be a symptom triad of jaundice, right upper quadrant pain and fever in patients. So what makes that different from the cholecystitis is the jaundice, and that's normally because there is an obstruction somewhere in the biliary tree. And the management of these patients, again, they'll probably be quite unwell, so manage them how you would any other septic patient, as discussed before. Antibiotics, fluids, hemodynamically stable and good analgesia for symptom relief, and an antipyretic for the fever if needs be. I just put together a little comparison table in terms of presentation to help us differentiate between the three different conditions.